The inguinal canal is a canal in the lower abdominal wall from a space extending from the anteroesophageal spine to the pubic tubercle, from which the testes comes out from the abdomen and goes into the scrotum. The canal is so placed that it is oblique, and as the abdominal pressure increases, the canal anterior and posterior wall close and don't allow anything else to come up. Now, that inguinal canal is anteriorly bounded by the external oblique muscle. The external oblique muscle winds round itself, converting into an inguinal ligament. So this is the external oblique muscle, which winds round itself. This is the external oblique muscle, which winds round itself, converting into a inguinal ligament. And this ligament extends from the anteroesophageal spine to the pubic tubercle. And it forms the gutter, which is the inferior wall of the inguinal canal. Posteriorly, you have the fascia transversalis. The anterior wall is strengthened laterally by the rising fibers of the internal oblique and transversus abdominis. These are the rising fibers. They arch around above the contents of the inguinal canal, that is the spermatic cord, and they form a conjoined tendon which is inserted on the pubic tubercle. So this hand, the thumb, represents the rising fibers of the internal oblique, and this represents the conjoined tendon. The hand itself represents the conjoined tendon. Thus, a gutter behind which is the fascia transversalis, this is the fascia transversalis, is converted into a canal, and there's a opening in the fascia transversalis, which is the deep inguinal ring here, and the inferior epigastric artery passes through the medial part of the deep inguinal ring. That is how it is recognized. So this is the inferior epigastric artery. It gives the accessory obturator artery, which we have told you that it passes through the lacunar ligament, can be divided when you are trying to reduce a femoral hernia or trying to plate the fractured pelvis, and it bleeds from both sides, can lead to death, and therefore it is also called as corona mortis. So this is the abnormal obturator artery. Okay. Then the boundaries are therefore anteriorly the external oblique, inferiorly the inguinal ligament. Anteriorly, the lateral part is strengthened by the rising fibers of the transversus abdominis and the internal oblique, originating from the epinerosis of the external oblique. The roof is formed by the arching fibers. This is the roof. And they end in the conjoined tendon, which strengthens the medial part of the posterior wall of the inguinal canal. So the inguinal canal is very deep on the lateral side and very superficial on the medial side. And then the spermatic cord comes out through the external oblique by a tendon, by a ring, which is a ring like this in the external oblique, and the spermatic cord comes out, goes through the scrotum, gets converted into the epididymis and holds the testes in the scrotum. In the scrotum. So this is the external oblique from the deep inguinal ring to the superficial inguinal ring in the external oblique is the inguinal canal. To repeat, inguinal ligament is the inferior gutter, external oblique strengthened by internal oblique and transversus abdominis laterally form the anterior boundary. The roof is the arching fibers of the of the transversus abdominis and internal oblique, and the posterior wall is fascia transversalis with a deep inguinal ring and an infraepigastric artery, which is giving the accessory obturator artery. And finally, the medial wall is strengthened by the conjoint tendon. By the conjoint tendon. And this infraepigastric artery is passing in the lacunar ligament and is called as the corona mortis. The spermatic cord has 3 layers. The superficial layer is from the external inguinal ring. The intermediate layer is from the muscles, arching fibers, which form the cremaster muscle. And the internal layer is from the fibers, the deep inguinal ring, the fascia transversalis. And the contents are the vas deferens, the pampiniform plexus of veins, the genitofemoral nerve, and the testicular artery. So, what is the pathology in the inguinal canal? It leads to inguinoscrotal swelling. It is not scrotal only, but inguinoscrotal, because you cannot reach above the swelling by pinching on the base of the scrotum. Now, in a hernia and also in a varicocele, hernia is an extrusion of any content of the abdomen from the deep inguinal ring into the inguinal canal. That hernia, the cough impulse will become positive, and the hernia can be through the deep inguinal ring, where this is the artery. So it can be lateral to the infraepigastric artery, or it can be medial to it. So this is called as indirect hernia, and this is called as direct hernia. Hernia can be of 2 types, and the cough impulse will be positive. And if you obliterate the deep inguinal ring by your thumb, after reducing the hernia, the cough impulse will become negative with the indirect hernia, but will remain positive with a direct hernia. So, then there can be the varicocele. If you obliterate the varicocele, reduce it, then you obliterate the deep inguinal ring, and then you make the patient stand up. When you leave the deep inguinal ring, the varicocele will fill from below and the hernia will fill from above. Then if there is a painful inguinoscrotal swelling with fever, with chills and rigor, then it is probably filarial funiculitis, which is the involvement of the lymphatics. So this much about the inguinal canal.